Hi, everyone. So we are still letting a couple of people in, but obviously I want to get us started so that we can stay on track. Good evening. My name is Washika Torres. I go by Miss Torres, MYST.TORRES. So please just introduce yourself in the chat. There is a check-in form that Nandini has put in the chat as well, so please make sure you fill that out. If you have any questions during the presentation, please put them or any comments you have in the chat as well, and we will try to get to them during the last 10 minutes of our speaker. There will be about 10 minutes for questions at the end. If we don't get to yours, we are sorry, but we're going to try to get to as many as we can. Here is a brief overview of the Zoom controls. There's a mute button right on the lower left-hand corner, followed by video. There's security information. If you want to mute or unmute, you would click the mute button. Most of you, or I think all of you, have come in on mute. If you want to have your video on, you can. That is not a requirement. If you need to stim or relax or step away or something happens, we understand. So your camera being on is not mandatory. But if you did want to, there's a little camera on the bottom that starts and stops your video. And if you click on the chat box, it will open the chat or close it so you can add questions. So to get started, like I said, my name is Washika Torres. I'm sorry. Hello.
I've been putting in the chat that the sign-in link doesn't appear to work. Could you please check it?
Sorry, could you the check-in form is on for everyone. So I guess, Nandini, would you be able to just reshare that? Thank you. Thank you for letting us know. So I am the course instructor, Washika Torres. I use all pronouns. And then we have Nandini Sarap, who uses she, her pronouns. She is also here, one of the TAs, and also Katie O'Neill, who also uses she, her pronouns. She is also another TA. Would you two like to introduce yourselves?
Sure, I can go. Hi, everyone. My name is Nandini. Like Washika said, I use she, her pronouns. I'm a second-year student doing my MPH in health and policy. And yeah, I'm excited to be here.
Great.
Hi, everyone. I'm Katie. I use she, her pronouns. And I'm in my first year of my MPH in Community Health Sciences, and I'm looking forward to spending the semester with everyone.
Thank you. They are the backbone of this class, and I mean it in every single way. They're almost all the bones. So, and I'm a fifth-year PhD student in the Disability and Human Development Department, doing a PhD in Disability Studies. And I've taught this course previously 2 years ago, and it has just been really great to be able to teach and learn from everybody, community members, students, and others included. So let's get into the course. So one moment. So this annual course is free and open to the public, and it prepares public health leaders and community members with the tools that they need to bring about social change and address structural determinants of health. All course meetings will take place virtually, and the course is open to students and the public from 5:30 to 6:30 p.m. CST. Students taking the course for credit, they will stay from 6:30 to 7:30. There's another link for them for a closed discussion and or an action lab. And Epidemics of Injustice is sponsored by the Collaboratory for Health Justice at the UIC School of Public Health. So thank you so much. We do also want to offer a content warning. Today's lecture and many of the other lectures will contain material that might be difficult to discuss. If you need to step away to take care of yourself, or you need to speak to one of us about the materials, you may step away during the presentation. And if you have any issues before, during, or after, please feel free to email myself or any of the TAs, and we will speak to you. I also would like to do a land acknowledgement. So the Collaboratory for Health Justice acknowledges that the University of Illinois Chicago resides on the traditional territories of the three fire peoples, the Ojibwe, the Ottawa, and I'm not great at pronouncing things, I'm sorry, Bodawanbi. Purchased after 2.5 years of open warfare, decades of violent encroachment, and the defeat of a pan-Indian movement to keep settlers out of the Great Lakes region at the Treaty of Chicago in 1821, receiving their final payment before moving westward in 1835. The area was also a site of trade, gathering, and healing for more than a dozen other Native tribes. The state of Illinois is currently home to more than 75,000 tribal members, and the Chicago land And the Chicagoland area is currently home to one of the largest and most diverse urban Native communities in the U.S. Illinois is also the territory of the Ho-Chunk, Miami, Anoka, Menominee, Sac, Fox, and their descendants. By making this land acknowledgement, we recognize that Indigenous peoples are the traditional stewards of the land that we now occupy, living here before Chicago was a city and still thriving here today. As we work to live and play on these territories, we must ask what we can do to right historic wrongs of colonialization and state violence and support Indigenous communities, struggles for self-determination and sovereignty. I also did want to point out some community guidelines as well. Please make sure you show up on time and come prepared. This is especially pertinent for students, obviously. Please let everyone participate. Please know people participate in different ways, in different forms, and sometimes it may take time for them to get all their thoughts out. Listen and have an open mind about these topics. Have mutual respect and appreciation for one another. We all learn from one another. You don't just all learn from me. You're not just little sponges absorbing information. We all learn communally. And respect the privacy and personal information shared during class. As we said before, there are a lot of content warnings. There's a lot of sensitive material and people may be sharing sensitive things with all of you. And we just want everyone to have mutual respect for that. So our first speaker who generally kicks off the series, I'm so glad that she came back, is Dr. Rae Murray. I'm going to read a short bio from her and then we'll go over one more slide and then we will get started. So Dr. Rae Murray has spent her career serving the medically underserved. She has worked in a variety of settings, including medical director of the federally funded health center Winfield Moody, which served Cabrini Green Public Housing Project in Chicago, residency director of occupational medicine at Meharry Medical College and bureau chief for the Chicago Department of Health under Mayor Harold Washington. Dr. Murray is the recently retired chief medical officer for the Cook County Department of Public Health. She also practiced as a general internist at Woodlawn Health Center, was an attending physician in the Division of Occupational and Environmental Medicine at Cook County Hospital, and is an adjunct assistant professor at the University of Illinois at Chicago School of Public Health and Occupational and Environmental Health, and the Health Policy and Administration departments. Dr. Murray plays a leadership role in many organizations, including the National Association of City and County Health Officials, Health Equity and Social Justice Team, the National Executive Board of American Public Health Association, and serves on the board of the Chicago-based Health and Medicine Policy Research Group. In 2011, Dr. Murray served as president of the American Public Health Association. She is the co-chair for the Urban Health Program Community Advisory Committee at UIC. Dr. Murray has been a voice for social justice and healthcare as a basic human right for over 40 years. She remains passionate about increasing the number of Black and Latino health professionals. So please give a warm welcome to Dr. Rae Murray. I will stop sharing my screen now so that she may share hers. And have a great session.
Well, good evening, everybody. I'm glad that you all have signed up for this course. Let me get to the right screen sharing thing. You all will tell me if you can't see anything. I want to take just a few minutes and talk a little bit about the history of this course. This is one of two courses in the school at the present time. Hopefully soon there'll be more that was organized and fought for by students, by your predecessors. And so this course was originally thought of and conceived and organized by a student organization. And I just want to acknowledge that. It's been institutionalized. That's a good thing. The other thing that I want to do very quickly, even though we've done an acknowledgement, you can read this later, you'll have these slides, but I wanted to go a little bit more in detail of what that means for Native Americans in the Chicago area. I think the acknowledgement that was used at the beginning of this course is great. It gives you already more information than usually is given in that. I don't think we should do land acknowledgements just as a quick ritual. I think it means we should take a moment and understand what's going on with our Indigenous communities. So as the previous land acknowledgement pointed out, this was a hub. We are in the Midwest, after all, in the middle of the continent. So this was a hub for a whole range of tribes. And there's a whole long process, not simply the Treaty of Chicago in 1933, where Indigenous people in this area were in wars. Their territory was taken from them. These are a series of treaties, most of which we violated, including the one in 1933. So we're in the wrong direction here. So that's important, but probably the most important thing, just to look at our highways and the villages, the most important thing is the Indian Relocation Act of 1956. This is really what has cemented the character of Native Americans in our city in the metropolitan area. In 1956, the federal government decided in their process of eliminating, quote unquote, the Indian, to try and relocate, to intimidate and force Native Americans to relocate off of their reservation lands and disperse them across the country. Chicago was a major destination point for that process. And that is why in Chicago, we have such a large number of Native Americans in an urban setting. And we also have a wide, diverse grouping of people from, I think, over 170 different federally recognized tribes. This is in 2018, where there was a ceremony recognizing the American Indian Center, which the one in Chicago is the oldest one, the oldest urban center that exists in the country. So in fact, in lots of things that we usually don't talk about in the School of Public Health or anywhere, Native Americans not only used to be here and the land used to be theirs and it was stolen, but they're actively here and participating politically in the life of our city and nation. And so one of the things that I want to do in this lecture is try to give you a framework, which I hope will aid you in tying together all these epidemics that you're going to go through in this course. You're going to hear about climate change. You're going to hear about restorative justice. You're going to hear about critical race theory. You're going to hear about immigration. You're going to hear about lots of things that we tend to think of, especially in public health, as sort of problems or issues. And what I would like to suggest that if you are going to be a public health professional, or if you're going to understand the role public health plays in the world, and certainly in our country, you have to fight, and it is a fight, for you to convince yourself or adopt or think about what framework ties all of these epidemics together. Are these just accidental epidemics that are going on, accidental problems? We have, you know, how many millions of people in this country unhoused, or how many people are unemployed? Or is there something that ties this together? And how do those things impact the health of the public, the health of ordinary people? So I can't, in this one lecture, go into a lot of detail in that, but I want to give you enough information, and I'm going to be giving you lots of books. Don't write it down. You'll have the slides to look at to help you make that framework for yourself, especially those of you who are students in any arena. For those of you from Chicago, hopefully these pictures are familiar to you. These are pictures that come to us from the riots, the race riots in the 20s in Chicago. There's a whole series of these around the country. And so this is going on actually on the south side of Chicago. But that's not why I'm showing it to you. I'm showing it to you is that this problem of this race riot in 1919 and 1921 has a report, and I'm going to give you a link to it in a minute. It's important when you come across a problem: gang warfare, homicide, adolescent homicide, unemployment. You need to ask yourself, how did we get in this mess? Where do these problems come from? Before you can start wondering about what to do about them. So this particular report, there was a commission report after this race riot in Chicago, like many that existed in the same time period. That was an official report, and it talks about the major problems that existed. It's called Negro in Chicago, 1922 is the date of the report. This is one book this has nothing to do with the 1922 riot. This is a recent book that tries to discuss power and inequality in Chicago. It's an excellent book, and I invite all of you to look at it. It explores some of the structural elements that make Chicago what it is today. So this is from the Negro in Chicago report. And again, this kind of framing of issues should sound somewhat familiar to you, and it should disturb you. So there are some people who felt that some of the problems that existed in 1922 that caused this crowd of white people to go into Black neighborhoods and kill Black people One of the problems, according to criminologists, is the warped mind of Negroes. And what this is basically saying is that because of oppression of Black folks, their minds got warped and they had a pathological attitude towards society. Interesting way to frame it. Think about that. They also talked about an environment that they felt was conducive to crime. And again, here they're looking at Black communities. And finally, this is probably their most useful comment, is the existence of athletic clubs. And those of you that aren't from Chicago may not know this, but these were basically white supremacist clubs, white young toughs that were responsible, according to this report, for this riot. We have a famous mayor. The original old man, Mayor Daley, was a member of one of these clubs and probably participated in the riots. So here's a look at the report. They have a number of recommendations, which you could easily make today. Most of them haven't been acted on. And so right here's the link for it. You can just Google it. The Negro in Chicago, 1922. You can find a PDF. How can you do a health assessment, a community health assessment, if you don't know about this report and if you don't have an understanding of the history of the city? You can't. You can't just look today in 2023 and say, oh, this is the demographics of Canaryville, or this is the demographics of Humboldt Park, and think that you have a clue what's really going on. It's critical in everything we approach that we at least ask the question of how we got there. What is the historical development of this issue that we're looking at? Sometimes we have the information, oftentimes we don't. And while I'm here, again, my major goal today is to give you an idea of other places you can get information and things you should be looking at. The UIC IRRPP reports are excellent. There's a link to them. These are reports that update the situation in the Chicago area. They talk about wealth gaps, income gaps, Native American community, Latinx community, Black community, Asian community. So this is a resource that you should be aware of and go to that site and find it. These listing of American values come to us from Dr. Kamara Jones, who's done yeoman work helping public health people understand racism. And she argues that these American values, the fact that we focus on the individual, that we forget about history, we have an ahistorical approach to all of these problems, that we're a country that treasures and reinforces a white supremacist ideology, that we think America is an exceptional nation, that just, it blows my mind every time I even say the words. How we think we're exceptional is beyond me. That we believe in a meritocracy, that we have a myth of a zero-sum game. So if someone gets something, someone has to lose something, and that we don't think a lot about the future. Dr. Jones argues that these American values are what prevents us from doing basic things that we should be doing. And so I know that you'll be talking about this later in the discussion. So we claim in public health that we are a science-based field. And we do that without thinking about what science really is. And so you should ask yourself, what do you think science is? In the past few years when we've been grappling with COVID, we should have some humility as public health people when we so glibly say this position or that position is science-based. One thing I can say about science is whatever we think it is today, it's likely to be different in 5 years or 10 years or 15 years. So I think that it's important to remember that science is a social institution like all the other things human beings create. And it can be influenced, as it has been historically, by the politics of the day and the religion of the day and the culture of the day. But to understand science, it really means you have to have some understanding of history, some grasp of history. And we're lucky or unlucky, I don't know how you put it, in our field, we don't have a lot of historical books that cover the broad breadth of American public health. Here are 3 basic ones, and if you read any one of the 3, you'll be in better shape than most of your colleagues. So I just refer you to that. And again, there used to be, way back in the ancient Neanderthal days when I was a student at the School of Public Health, we used to have a mandatory course on the history of public health. I'm sorry that we no longer have such a course. But you really do have to have an understanding not only of American public health, but obviously of Western Europe public health, and ideally one day of what public health means in other parts of the world. The second thing we're very glib about is what the hell do we mean by health? Now, there are different definitions. This first definition is just Webster's definition. I think this is what the typical American thinks about health. Physical and mental well-being, freedom from disease, pain, blah, blah, blah. Normalcy, the interesting word again, of physical and mental functions. Think about what normalcy means for most people. So that's what the normal, typical American thinks health means. The second dot is the WHO definition, which they adopted in 1948. Health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. This is an important advance over this sort of dictionary definition of health. And I will tell you again, many decades ago when I was a medical student at UIC, in our class, medical school class, one of our professors put this on the board and said, this definition does not apply to us in the United States, which I found amazing. But so this is not an easily accepted definition, and it doesn't mean that everybody agrees with it. The last definition, which comes to us from the People's Health Charter adopted in 2000, is clearly a political definition. It happens to be a definition that I am most comfortable with, but I'll take a moment. And this argues that health is a social, economic, and political issue, and above all, a fundamental human right. Just that one sentence. That is something that most American politicians, and certainly our nation, does not recognize, that health is a fundamental human right. Inequality, poverty, exploitation, violence, and injustice are at the root of ill health and the deaths of poor and marginalized people. Health for all means that powerful interests have to be challenged, that globalization has to be opposed, that political and economic priorities have to be drastically changed. I put this definition up here not because I want you to memorize it or get tested on it or necessarily even agree with it, but to let you know that in the world there are major debates about what health is and what you think health is, what definition you decide to work from, influences and colors everything you do, from what research questions you ask, what kind of work you do, what kind of interventions you design to try to improve people's health. And so you need to be aware of the debates and arguments. I guess that's the major problem I have with our typical education in schools of public health and medical, nursing, dental schools. We don't teach you what the arguments are. The People's Charter comes into existence in opposition to, as a criticism of, the World Health Organization. But we don't even talk about the World Health Organization very much in the United States, so we're really sort of behind the 8 ball. But try to ask yourself, what do people mean by that? What does it mean to have normalcy of physical and mental functions? Ask our colleagues in our accessibility program, and they'll have some different kind of ideas than what's expressed in that definition. Here's some other books that I just want to point out to you. I won't spend a lot of time on them, except these are foundational books in our field. This Epidemiology of People's Health by Nancy Krieger, who I think is one of our finest living epidemiologists certainly in the United States, but in the English-speaking world, is really a discussion of the history and the development of the theories behind epidemiology, which we pretend is a basic science of our field, even though we don't teach it like that. And this second book here is her newest book, where it encapsulates her career's work in terms of how she's developed what I think makes sense to me, this eco-social theory of population health. Again, we don't have time to discuss this in depth. This is what I go through, and we discuss the debates that exist around health inequities and social theories, or different kinds of theories of what makes population health good or bad in my spring course. But in any case, this is a theory upon which the WHO model is based, and it's a theory that I find useful. I also just want to, again, quickly point out some other books. This is a great series of books, especially the one on climate change. You're going to have a topic on that later. And I want to just do a shout out to Jaime Grail and our Latin American cousins. This is a description in English of their work on epidemiology. In my opinion, the Latin American School of Epidemiological Thought, Social Epidemiology, is the most advanced and most progressive in the world. I don't read enough Spanish to be an expert at it. And so I was grateful when this English version that pulled it all together came out again. I invite you all to look at that. So as an American or as a human on the planet Earth, you can't really talk about health and public health without understanding racism. Again, we don't have time to talk about it. I refer you to Dr. Jones. There's lots of things on the web. You can Google her name. But racism is a hierarchical system that built in, I like her definition, unfairly disadvantages some people and unfairly advantages other people and saps the strength of the whole society. Anti-Black racism plays a special role in world history, but it's critical to remember, especially in the United States, that racism is not binary. It's not simply Black or white. It's really an expression, I think, of when we talk about structural racism, it's really an expression of the development of capitalism. Now, again, I want to be clear. A lot of people don't agree with this definition. I happen to think this concept of racial capitalism makes sense. I don't think you can talk about capitalism without racism, and I don't think you can talk about racism without capitalism. That's just my personal opinion. But again, be aware that this is a major area of discussion and debate. When we think about health inequities and we think about work in it, you can ask different people when they think that work started. I think it goes back many generations, but I would at least start in the United States with Dr. W.E.B. Du Bois. This book, which is his seminal work on Black Reconstruction in America, if you haven't read it, you ought to consider reading it. It really discusses how we got to where we are today in 2023. And it's a critical understanding of the relationship between racism in the United States and capitalism. Another great book is Nell Painter's History of White People. Again, how can you understand racism if you don't have some understanding of the history of white people? And finally, this other book is also good. I do want to talk about, because my goal here tonight again is to talk about the different arguments that we have in public health. And so even though I have the utmost respect for Dr. Du Bois, I want to tell you about one kind of debate and argument that existed. Now, Dr. Du Bois is a sociologist. He's not a physician. He's not a public health person, but he had his notions. Remember, he's writing in the late 1890s, early 1902, 1906, about why the health status of African Americans, of Black people, is so much worse than the health status of white Americans. And one of the things he argues in the Philadelphia Negro, for example, is that as former slaves, Black people did not have the same level of understanding of the role of hygiene, were illiterate, and didn't really understand how to keep themselves healthy. This was one of his things. He thought this was based on racism, but he felt this was one of the reasons. Rebecca Crumbler, I hope I'm calling out the right sister, is one of the early Black physicians, female physicians in the history of our country, and worked with the Freedmen's Bureau. She disagreed with him, and she said, no, this is not because Black people don't understand how to be hygienic or what they need to do to not get infected. It's because they are forced to live in slums and have poor nutrition because they can't afford food. She argued for the social conditions, for the difference between the health status of the newly emancipated slaves and white Americans. So from the very beginning, we have discussions and debates about why people are sick and what is making people sick. And again, this is something that you have to understand and ask yourself and be aware of the debates. These are some more great books on history. Again, I won't spend time on them now, except to point out this is like a short version. I won't say it's Cliff Notes, it's better than Cliff Notes, but it's a short readable version, overview of Indigenous people's history. And this great book by Paul Ortiz is also very useful and gives you some more background in terms of Latin American and African American history. So let's look at some examples. This is an early debate that existed in our country before the Civil War. And it's a debate that still goes on today, period. So this is Joshua Clark Knott. You can see when he lived. He's a physician and a gynecologist. He is a major leader in American medicine, a brilliant man. He did major research on yellow fever and malaria. He's one of the founders of the first medical school in Alabama. He was also the medical director for the Confederate General Army Hospital during the Civil War. He was also, you'll not be surprised, I don't think, to know that he was a pro-slavery advocate. This is what he thought of me and my ilk. The Negro races stand at the lowest point in the scale of human beings. It is clear they are incapable of self-government and that any attempt to improve their condition is warring against immutable forces of nature. So that's Dr. Knott. Why do I mention him? Because we have some data, not from him directly, but from the Southern Medical Journal. And let me just, we didn't have peer review in 1849, but this was a prestigious, important journal. And this is what they published in their journal. They didn't have a graph like this. I made it into a graph. This was done in a narrative form. And this is what they observed. Slaves, in the view of especially the Southern physicians, but many physicians, not all, but many physicians in the United States, slaves were supposed to be inferior. They were supposed to be very strong and able to work in conditions that whites couldn't work in. That's why it was okay to have slaves, because we were built to be slaves. What else could we be? And so what this graph shows is that in Hancock County, the prevalence of diseases peculiar to women, those are diseases of reproductive origin in general, and miscarriages was higher. The prevalence was higher among slaves than among white women. This creates a cognitive dissonance, because if slaves are supposed to be stronger, more animal-like, able to work, how could this exist? This created a problem for our medical colleagues. So this was a question. This early inequity that they saw, was it from the conditions of slavery or constitutional conditions of the slave? That's the question that they asked in 1849. And this is their answer. I'm going to take time and read this because this is directly from the paper. You can Google this article and you can look it up and read it. This table of disease either teaches that slave labor is inimical to the procreation of the species from exposure, violent exercise, etc. Now, think about that. There's a possible hypothesis that's not unreasonable. I mean, it may be that working as a slave out there in the fields would make it hard for you to carry a pregnancy to term. Or, as the planters believe, that Blacks are possessed of a secret by which they destroy the fetus at an early stage of gestation. So these were the two possible answers that these scientists, using scientific evidence and the major, at least some of the major scientific thinking of the day, posed. This was their conclusion. In philosophizing upon this immense difference, we are led to the conclusion from the facts within our knowledge that it originates from the from the unnatural tendency of the African female to destroy her offspring. So we have data collected, we have possible hypothesis posited, and we have a conclusion drawn in the scientific, I think, in a perfectly typical scientific manner. And this question, is this inequity? Well, I shouldn't say inequity. Is this difference that we see in health status because of the constitutional composition of the people that have the bad health outcome? Or is there some other thing, other condition going on in society that's causing this difference? We fight about this today. Is infant mortality rates among Black women because they are too poor to go to the doctor and they eat flaming hots all day and they don't eat enough vegetables? Or is there something else going on in society to explain the fact that Black women with insurance, high incomes, and high education have worse birth outcomes than white high school dropouts? So those questions, even though it may sound obvious when you think about it in terms of 1840 and slavery, we still ask the same questions today. And unfortunately, we still pose them in the same way, because we don't ask the appropriate questions and we often don't have the tools that we should have to answer it in a reasonable way. These sisters are from the Young Lords, and I wanted to talk something else since we're talking about reproduction. Maternal child is a traditional field in public health. I want to talk a little bit about reproductive rights. We've just seen a reversal. So this is just looking at maternal mortality, and I just put this up here to remind you that the maternal mortality for American women is horrible. If you look at maternal mortality for white American women, it's worse than our peer countries. And we know that there are important racial and economic differences in maternal mortality. So now, not everybody cared about maternal mortality. So this is just looking at the rates, but so we have a fact that historically the maternal mortality of American women was not fundamentally that different than our peer countries, and maternal mortality was falling for all countries where we kept records of it until relatively recently, the past 20 or 30 years, where the United States went completely in an opposite direction of our peer countries. And that's an important question we should be asking. Why? So we have a long history of the eugenics movement in the United States. And I get furious. In fact, my blood pressure goes up when I hear people say that the reversal of Roe v. Wade is horrible because it's the first time a basic constitutional right has been taken from American women. This is just factually not true. We've taken constitutional rights from groups of people throughout American history, starting with Black people, for example. We were supposed to be emancipated and have the right to vote, except, and we lost all of that after those amendments were passed. So this is not the first time that a constitutional right has been taken from a population. But in any case, Fatty Lou Hamer is an important leader in the African-American freedom movement. She was a founder of the Mississippi Freedom Democratic Party, but she's on this slide because she had a Mississippi appendectomy. This is a situation where if for any reason in the South, abdominal surgery was done, Black women were almost always sterilized, and I shouldn't say almost always, were frequently sterilized in this situation. This happens to be a new book, biography of her, so another great book for you to read. These two physicians, Dr. Rae Murray and Dr. Helen Rodriguez-Trias, are leaders in the reproductive rights movement. Dr. Murray, a Cherokee Choctaw physician, did a study and documented in the 1970s. Now, this is not in the 1870s, this is the 1970s. In her population that she was looking at, that some 40% of Native American women had been sterilized and 10% of the men had been sterilized. Helen Rodriguez-Trias, again, a major leader in public health, a pediatrician, Puerto Rican pediatrician, also fought against this sterilization. They were disturbed in the 1950s that the birth control pill was piloted and used on Puerto Rican women first, the clinical trials, but that Puerto Ricans on the island had one point in time the highest rate of sterilization in the world. So these are two women of color, happen to be physicians, who fought hard against this abuse that was part of the eugenics movement designed to improve the human race and to decrease the population of quote unquote undesirables, which certainly included people of color. And finally, I wanted to give a shout out to Dawn Wooten, a licensed practical nurse, for blowing the whistle on 4 sterilizations that were documented to go on during the ICE, among some of the ICE detainees. And so she blew the whistle on that. So the issue then of sterilization and eugenics is not a new issue. It shouldn't be a surprise to anyone. And in fact, one of the reasons that we are in this trouble with Roe v. Wade is because we didn't pay attention to all of this. So while American white middle-class women, not even working-class women, felt that they had a constitutional right to control their bodies, this is not something women of color ever thought. And in fact, as a women's movement, and even the movement around abortion rights, which is a very narrow concept, it's a much narrower concept than the issue of reproductive rights. Think about that. The right to an abortion is not the same as reproductive rights. I don't know where this slide is, so let me just say it now. So one of the things that happened almost as soon as Roe v. Wade was decided was the passage of the Hyde Amendment. And the Hyde Amendment, it's renewed. It's been renewed every year. It varied over time, but in different years, it prohibited using Medicaid money or Medicare money to fund abortions. It prevented federal employees for some years from getting an abortion, prevented Native Americans through the Indian Health Service from getting abortion. There was a whole range of women whose rights to access to an abortion were prohibited by this Hyde Amendment. And this Hyde Amendment, in fact, was never really defeated, even though it existed for as long as Roe v. Wade did. Oh, here's the slide I was looking for. Okay, so this just says what I just said here. So always, even when Roe v. Wade was in authority, you could get access to abortion depending on where you were, what kind of hospital you had, what part of the country you lived in, how much money you had, what kind of insurance you had, if you had any kind of insurance. And so if we want to, in fact, have reproductive justice, we can't replicate a system that ignores those differences. I didn't discuss those books, but that slide with all the books, those are great books you ought to look at. Another thing that we say in public health, but I don't think we understand what it really means, we're too glib about it, is that we are data driven, which again drives me crazy because that 1849 data is there. The question is not what the data says. The data never says shit. Some human being says something about the data. We interpret, we even decide what the data is, and what is data. This is a group out of Washington State that I really like the approach that this group has. They are a Native American group, and they argue that they have problems with the data because they are often excluded from the data. And certainly in this country, no matter where you are, we usually can't find data on Native Americans or many other groups. But they've argued for an approach for data justice, which means that you need to have a research framework that pays attention to marginalized community. It needs to understand that how knowledge is created is not only through a Western frame. And again, that's something we don't have time to go into, certainly not in this hour, and this course won't even go very much into it. But we really need to ask ourselves, who creates knowledge? Who defines knowledge? What types of knowledge are we willing to accept? And in any case, today, when we have so much of our work that is supposed to be community-based, participatory research, what does this mean? Does this mean you just have some community people hanging out, signing off on grants with no power to control what the hypothesis, no power to control who does the gathering of the data, no power to determine what the data is, and no power to say what kind of questions we really need answered. And so here's an organization that's trying to bring some kind of light to that power struggle. The arguments that we carry on, argument is good, it's a good thing, to think about how do we define the problems that exist in our society, and then we can fight about how to solve the problems. And so this research and data justice becomes important, because without that, you can't really talk about justice in general. So this framework then becomes important. Can we decolonize the data? No, we can't. It's a problem. We do data in different ways, often for convenience, but we have to fight for and insist that the data gets done the right way. So, example, in public health, we have a horrible data infrastructure in public health. It tails other Western cultures. It's difficult for us to intelligently approach any problem. COVID is just the most recent example of this, where we weren't really clear on the infection rate. We weren't really clear on what's going on. And now that we're stopping free tests, we'll be even more in the dark. And so these questions of data, just because something gets published in the peer review doesn't mean that it's right. And it doesn't even mean it's the right data. One of the real problems we've had in recent time period in public health is how do we talk about police violence? And I'll tell you, and there are people in our school and other schools who would try to do research on police violence, and this wouldn't be published in any of our journals. People would say, that's not a real thing. We're not interested in police violence. That's not something our journal looks at. And in fact, even at APHA a few years ago, where young students fought for trying to talk about police violence, our learned faculty said, well, we don't have peer-reviewed literature on this. Well, how do you get peer-reviewed literature? You have to ask the question. You have to be willing to explore the question. You have to be willing to approach collecting information about the question before you can really decide whether you have a problem or not. And so again, this is a political question. It's often argued about. And we've seen this over and over again in the history of public health. I don't care whether you're talking about occupational diseases, diseases that workers get on the job from their job, or whether you're talking about trying to count how many people police kill each year. So we had a situation where the best data on how many people American police killed came from the Guardian newspaper in the United Kingdom. Not because they had any magic, they did the basic grunt work that we always do in epidemiology. I'll explain it to you. They looked at the American newspapers and they would see somebody got shot, blah, 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 by the cops. And they followed up with that information, called the family, called the local people, documented it, and they actually had an excellent database of that. This is how we've done mortality with occupational diseases, to how many people, how many workers died on the job. Through our normal public health data systems, we were missing a third of those occupational deaths. And so we did the same thing that the Guardian did. We looked at the newspapers and we documented that we were missing a third of the deaths. Why is it that a newspaper has better data than CDC or the Department of Justice? It's only because we make a decision not to count those deaths and not to keep track of them. Here's another local example where we did good as a school. So I do want to do some shout outs where we do good. This is Sister Hazel Johnson, really one of the mothers of the environmental justice movement from the far south side of Chicago. You can read about her. But as you know, or you may maybe not remember, there was a big controversy about the movement of General Iron from the near North Shore side here to Chicago's Toxic Donut. That's that little thing there's Oakdale Gardens, where they wanted to basically move this shredding plant from a white rich neighborhood to a poor Black and brown neighborhood. And this is really where Sister Johnson worked for decades in Oakdale Gardens. So here's the General Iron history. This on the left is the North Branch of the Chicago River, where they are, and this is where they wanted to move to on the far south side. And there was a community demonstration for over several years against this move, not unusual in Chicago. This happens to be a copy of a letter that the school generated. So both the Collaboratory for Health Justice, our environmental people at the school, the dean, along with some 70 or 80 other organizations around the city, over 500 public health professionals of different types, all objected to this. And as you may or may not know, this permit to allow them to move and open up the plant there was denied. Environmental justice is a major problem in any old urban center like ours. And so this effort to deny the permit actually was successful. But you have to ask yourself, how did this happen? What's the history of this? This is a great book by Dr. Pello on garbage wars, as it says in the subtitle. It's a discussion of some environmental justice movements in Chicago. And what I like about this book, it talks about, this is an alley somewhere in Chicago. I think it's somewhere near where the university is actually. In 1898, the mayor of Chicago, I don't remember who that was, appointed Jane Addams as the first woman garbage inspector. And in fact, there were people out of Hull House that functioned as local area garbage sanitation inspectors. If you grew up in Chicago, or if you understand Chicago history, This is an important political position within Chicago. So each ward will have someone in charge of streets and sand for that ward. Do the alleys get plowed? Do the streets get plowed? Does the garbage get picked up? This is a problem that existed in 1898 and it still exists today. So this problem of what areas of the city were allowed to exist like this, with garbage thrown all in the alleys, and what areas didn't. And again, it's not enough just to look at an isolated fight for a permit or an isolated fight for an incinerator or an isolated fight for this. Is to understand how is this problem of environmental racism tied up with the broad environmental movements. It's been over 30 years when the first National People of Color Leadership Summit took place in 1991. It included all people of color in North America and a number from outside of North America, and adopted a set of principles. So again, not simply saying we're against environmental racism, we don't want you to dump here. That's fine. But actually saying, no, we're for environmental justice. And here are the principles involved in that concept of environmental justice. So that's what we have to ask ourselves.
So, Dr. Murray, so I know you have more slides in your slide deck, and there's all the slides are going to be on the Google community set, the Google page, the Google Classroom and community site. But we also wanted to make sure, since some of our community members we have to transition soon to our group discussion. So these will be on Blackboard, the Google site, so you'd be able to see them. And also all the books recommended are also on the Google site, so you'll also be able to see those as well. And we really wanted to thank you for the presentation portion, and we really wanted to transition to asking questions. Someone can relink the Google site, but I also did want to take the time. I did not get to mention it before. I'm very sorry. That we also wanted to thank the Radical Public Health for the creation and support and the promotion of this program. RPH is celebrating 11 years. And for more information about RPH, you can actually visit their Facebook page. So it's facebook.com/Radical Public Health. So we are extremely grateful to them. Just like Dr. Murray said, a lot of this creation of this class has been pushed by student power and student collective work. And we want to make sure that we recognize and honor that. So I'm really, really happy. But we do have some questions that students wanted to ask you. We have a couple. If there's others that want to ask, please make sure you put questions in the chat. We do have a running list, and we'll try to get to as many as we can. So one question was, how can social epidemiology be used by social workers and community health workers to address needs at the individual and community level, as well as by politicians and advocacy workers to address needs around systematic and structural levels of inequity that impact health? And I will also and that will also, thank you, Nandini, will also be in the chat. Yes, that was an amazing presentation. But yeah, the question is also in the chat. If you would like to read it again, or if you need me to read it again, just let me know.
So no, that's fine. Let me try to approach it this way. That's an important question. So I spent most of my career as a practicing clinician, a practicing general internist. In addition to other things. And so I think there's not a contradiction between thinking about things in a broad, holistic way. What are the structural components with how we got messed up, and addressing the individual patient? Okay, those aren't in contradiction. And so let me give you an example, hopefully, that illustrates that. The Black Panther Party, which actually has a excellent and profound impact in their understanding of health, how to change how we do health. If you looked at the Black Panthers breakfast program, they had breakfast programs for elementary school kids, so they could go to school with breakfast, okay? If you looked at their breakfast program and you looked at, I'm just gonna use the Catholic Church as an example, the Catholic Church's breakfast program, the breakfasts weren't different, okay? They were healthy, good breakfasts. The difference was that the Catholic Church didn't have an analysis for why it was those people needed free breakfast. the Black Panthers had an analysis for why the children didn't have breakfast, and they taught that analysis to the children and the communities and the parents of those children. So that's the fundamental difference. If you don't have a structure, if you don't have a theory for your epidemiological concepts, if you don't have a theory for how populations stay healthy or become sick, then you're left with just band-aids that you constantly do. You need to do badly. If somebody's bleeding in front of you, you need to stop the bleeding. That's the first lesson as a physician. Otherwise, the patient will be dead by the time you have a revolution or something. So it's not that you don't put on the Band-Aids. The point is, do you have an approach that allows you to solve the problem fundamentally? So that's why I ended up on this, my last slide. We really have to pay attention to that. We have to explicitly state what we think is important, what our values are. And we have to spend time asking the questions, even though it may not change how you prepare the breakfast for kids or how you apply a Band-Aid on somebody that's bleeding. I don't know if that helps. So yes, epidemiology in all of its forms will be helpful, just as much as anthropology and history, all kinds of other things too. We need to bring to bear all the tools we can manage on these problems, because we are in big trouble as a nation and as a world. And many folks attribute all of social determinants of health as it. Well,
sorry, we have like a running list, so I have.
I'm sorry. I'm just looking at what's on my screen. So
I know. So the other question was, how do we work to change the systems that contribute to and perpetuate racism, inequalities, and injustice? Since these systems were built to keep non-white, non-Christian men out, is it even worth trying to change them from within, or would our time be better spent working to dismantle them from the outside? What are some examples of what that looks like?
So I'm sorry to keep giving these glib answers. When you are engaged in a fight, you need people everywhere. So to answer your question bluntly, you need some people inside, you need some people outside. You have to fight at every point. And you don't have an option. It's a luxury to think you can ignore one piece of it. You can't, okay? You can't ignore what the part of the system, because the system is oppressing all of us. And so I would say, obviously, people individually can choose where they want to put most of their emphasis, but I certainly am not distressed with people that are trying to fight, quote, from the inside, whatever they think that means, or from the outside. We really need to need to have an inside-outside game, and you better be in communication with each other.
Great answer. So another one was, many folks attribute all of SDOH as health equity. Can you differentiate them for us with differentiate the two for us? I believe there might be instances where health equity can be SDOH, but not all SDOH is health equity, or am I in the wrong?
No, you're not in the wrong. So first of all, let me just say this while I scroll back here. The social determinants of health, we misuse that word. I don't know what people think that means. Health equity is looking at outcomes, and social determinants, all of health is socially determined. I'm trying to get to my little, oh, here it is, there we go. So this graph here, this graphic interpretation, the social determinants of health are intermediary factors. They're not root causes. They're not structural, okay? Mm-hmm. The social determinants of health are things like they're related to structure, but they're not quite the same. And that's why this kind of eco-social theory allows you to better place, quote unquote, social determinants of health. But most Americans, including most American public health people, I think they are using the wrong definition of social determinants of health. If you're rich, okay, Bill Gates is rich because of social determinants of health. Okay. Somebody else may be poor because it's not a character defect, social determinants of health, social deficit. It's just describing the process where what determines whether you're healthy as an individual, and certainly what determines whether you're healthy as a population, is socially constructed and determined. That's all social determinants of health mean. So I don't think they're related in any kind of direct way with health equity, if you have social determinants of health that I value, you will have health equity. But
Yeah.
if you have social determinants of health that our country values, you have inequities.
Mhm. Wow. I mean, that's amazing. Thank you so much. Like, honestly, every time I hear your lectures or see your slides, it's just, yeah, like someone commented, it's super profound. And yeah, so wow. So we will be ending this session, and for all students, for all community members, thank you for coming. This was amazing. I do have one more slide that I want to share. One moment. For all of you, I have where is it? Oh, no, that wasn't it. I'm trying to find, not, unfortunately. Oh, here we go. Sorry. So if you enjoyed the session, please consider donating to USC SPH, the SPIH Collaboratory for Health Justice Fund. Your donation can support closed captioning, translation service, ASL interpretations, honorariums, and travel costs for our guests. And there's like a link for it as well, and all future events for the Collaboratory for Health Justice. And I did want to let all students know so thank you all for the community members for coming. We will now transition to our class discussion. So for all students, please make sure you go to the link in Blackboard, go to the Zoom room, and then go to the class discussion portion. And we will be transitioning over there. This has just been amazing. Thank you all so much for joining us. And we hope to see all of you in the coming weeks so that you can enjoy and fully engage with the work that we've been doing, and that next week is climate change. Yay! So we are, again, thank you, Dr. Murray, for coming and sharing all of your insight and wisdom that you've accumulated over the years with us. It has been really great. So all students, please begin to transition, and we will see you there.